Missed empyema or partially treated unresponsive pneumonia, encysted empyema, how is the management different? In this, if it is the encysted empyema, generally speaking, a VATS is the answer, don't delay. If it is missed empyema, then you will, when you put the, for a tapping, you put a needle inside or a cannula inside and you see thick pus, put a chest drain and use fibrinolytics. And urokinase is the most easily available, while alteplase is the more, probably the more effective or the more studied or the more recommended or the more commercialized. Then role of identification of pathogens. In this patient, I told you that a nasal swab had been done, which was compared probably useless. It was not required. We were having a leukocytosis. We were having a pneumonia on auscultation. It is likely to be a bacterial one. And nasopharyngeal swabs. The BioFire, the standard BioFire does not do bacteria in this. Standard BioFire does not do bacteria even in pleural fluid, which is the enclosed fluid, not exposed to, but because they have not standardized it, they have not standardized for that, they say we will not, we refuse. When we, just imagine we are sending for a test which costs them 25,000 plus, they must be making big money out of it, but they say we will not do it in this particular sample. I think, but there are substitutes of it who are doing it. I'm not too sure about the veracity of those, so I will not go any further in that. So once you are able to identify the pathogen, which in this patient, another patient who was similar, we had a bronchoscopy, we had obtained a bronchoaerial lavage, patient was very similar. This patient turned out to have on BioFire a pneumococcus and not a staphylococcus, which was our suspected diagnosis. Patient is still there in my ward to be discharged on maybe tomorrow. So that one has nematoceles all over. We were vouching for staphylococcus. When the patient came to us, it was failure initial treatment somewhere. Ceftriaxone or vancomycin were already being given. We continued the same. And when we saw those nematoceles, we were convinced that staphylococcus, but our bronchoscopy, which was done because of a collapse, we were trying to open that collapse, it showed pneumococcus and not staphylococcus. Then that means identification of pathogen in a bronchoaerial lavage or in an older child who can produce a nice sputum, not saliva, a proper sputum that can also be tested by BioFire and a good lead can be taken from it.
Just adding a point over here, sir. In our setup in our institution, Dr. Tapesha is here. She has just made a poster presentation on this part. A pleural fluid has been used off-label for identifying the organism, and in one of such situations where we were suspecting a necrotizing pneumonia because of staphylococcus and other things, we found pneumococcus and we were able to de-escalate the antimicrobials and do it. And a couple of other patients also, Tapesha is here, who made this presentation at the international forum. So it's an off-label use. It is not a specified usage of pleural fluid being subjected to BioFire, but then I think things are going to move further in future also. We'll be having more.
We also did, when one of these patients kind of cheated the lab, and we got a mycoplasma which appeared convincing. So in that sense, probably once they say, yes, we have standardized it and we'll do it, I think it will be a good test.
Yeah, thank you.
Good.
Can you share some of the challenges which you have?
Yes, challenges are many in this field. Next one, please. Fluid seen on the ultrasound, but TAP fails. That's a challenge. What do you do next? Maybe just continue antibiotics and hope that either patient will improve or the fluid will increase and then you will get another opportunity. I don't see any other way of proceeding in this situation. Fluid is straw colored, looks tubercular, but has mainly polyps. Now this is also a challenge because many times, if not many times, sometimes, occasionally at least, it can happen that the fluid is actually tubercular and still has polyps. So that does not necessarily tell us what, like in this patient that we demonstrated, mainly lymphos and it was a bacterial infection. Then fluid straw colored, looks tubercular, has mainly lymphos, but ZN stain is negative, expert is negative, and there is no parenchymal lesion. Now this is a very difficult situation because ZN stain and expert negative is quite expected. It is, positivity rate is very low. Even for expert positivity rate, because fluid in tuberculosis many times a hypersensitivity reaction rather than a actual bacterial invasion. So you can get negative one. But parenchymal lesion is also not there, then it becomes very difficult. I would do a CT scan in this and look for possibly some parenchymal lesion which is being missed, or a lymphadenopathy in the mediastinum which will give me further lead and tell me whether a EBUS kind of sample can be taken for further test. Then fluids show many septae on ultrasound. TAP shows thin fluid. Should I go for VATS or straight away? Now in this septae, to my mind, forever since ultrasound has become the test for pleural fluid, septae on ultrasound are overdiagnosed. Many a times septae will be there, you tap and thin fluid like this one I showed you comes out, and you can just put a tube in a day or so, it all resolves, or maybe 2 days, 3 days. So septae on ultrasound is not a reason to me for going for VATS straight away. So thin fluid especially, then I will rather put a chest tube, and if the fluid is thick, I will use the fibrinolytic, and if that fails, then only go for VATS. Next is requires fibrinolytics but doesn't tolerate. Yeah, this has happened to us occasionally. These fibrinolytics cause a lot of pain and sometimes rigors and chills. So then it becomes very difficult to continue with them. We try to dilute, we try to give a smaller dose, we try to give small dose more frequently, try these tricks. If that still don't work, then maybe we just have to give them up. Urokinase, streptokinase is the biggest culprit, which we normally don't use. Urokinase,
I think we'll have to wind up this particular aspect. We'll have to go to the next point because we are running short of time.
Okay, fluid is drained, but fever is persisting. Fluid fully drained. I told you it could be because of necrotizing pneumonia. CT scan ordered by a colleague outside, but contrast not given. Well, you have to still protect your colleague. Surgeon wants to operate, but I want to wait. Well, this can happen, or vice versa. Sit down together.
Right. Thank you very much for this wonderful information which you have shared with us. Dr. Chuk, we'll just bypass some of these things and go quickly to Dr. Manish, who is Director Professor of Pediatrics at UCMS in GTB Hospital. And intra-abdominal infections, liver abscesses, they are very oftenly missed in the initial assessment in the child. What is the best modality imaging which you recommend for intra-abdominal infections or visceral infections which may be there? Dr. Manish?
Thank you, sir, for inviting me. The best initial screening modality for diagnosing liver abscess is definitely the ultrasound. In experienced hand, it has a sensitivity of about 85%. Apart from it, it is portable, easily available, and does not give any radiation exposures. However, in certain cases, we require contrast-enhanced CT scan, like in deep-seated abscess, gas-filled abscesses, or multiple abscesses in areas where ultrasound windows are not very clear. But MRI is generally not required. But in cases like renal insufficiency and allergy to the contrast, then we go for MRI. Or in cases where the follow-up imaging is required and you don't want to take a cumulative radiation exposures. Otherwise, generally MRI is not required.
So, can you, from your experience, tell us how to manage a patient with a suspected liver abscess, or it comes with a fever which is not responding and there is some pain and there is some image which shows there's a collection of pus? How would you proceed? We'll talk about the predisposing factors later on. Out of your experience, which you mentioned while we were discussing, a child came with a toothache and you had this experience.
One of the case, I have a very fascinating case to share. A child came with a fever of about 10 to 14 days and right-sided hypochondric abdominal pain. TLC showed leukocytosis and CRP was raised. Ultrasound showed definite liver abscess. Now the case becomes interesting over here. We proceeded with IV antibiotics and aspiration of the pus. And then aspiration of the pus, that is the pus culture, showed Streptococcus angiosus. This is the organism generally found in the mouth. Then we looked at the mouth of the child. The child had multiple dental caries and gingival abscess. So that was the bacteremia from there that was seeding the liver. So this was the tooth that troubled the liver. Subsequently, dental caries were treated, abscess was drained, and the liver abscess were treated and the child became all right.
So do all liver abscesses require drainage, or some of them can be treated conservatively also without putting in any
No,
needle?
sir, all liver abscess don't require drainage. Most of the amoebic liver abscess, they don't require drainage. Unilocular, less than 5 centimeter liver abscesses, they don't require any treatment. And we don't go for the drainage if the child is hemodynamically stable, responding well to the antibiotics, then we don't require drainage. But however, in certain cases like multilocular, however, in certain cases where the child is not responding to the antibiotics, there has been more than 72 hours, child is still running very high grade fever, is having excruciating abdominal pain, or ultrasound shows the increased pus collection as compared to the previous one, and the size of the abscess is more than about 6 to 7 centimeter, and the volume is more than 100 ml, and there's a risk of rupture. Then only we go for the aspiration. Otherwise, we generally don't go for the aspiration.
So do these lesions resolve on ultrasonic follow-up examinations? How do you follow up these things? When do you decide to stop the treatment?
Sir, actually what happens is total duration of antibiotic in liver abscess that we treat is for about 4 to 6 weeks. IV antibiotics generally we give for about 7 to 14 days. But the repeat ultrasound generally is done at 7 to 10 days to see whether the abscess size is decreasing or not. And if it is a multiloculated or any complication we suspect, then we repeat it at 4 to 4 weeks. But at 6 weeks when we stop the treatment, ultrasound is still showing